For everybody who is here right now, and for those of you who will come, it is truly a pleasure and an honor to introduce Art Curley. He's one of the top dental litigators in the United States. I first met him, I believe you lectured at the Seattle Study Club many years ago, correct?
Yes.
Yeah, so I first had a chance to see him a number of years ago, and I was really impressed by what he spoke about because he's pragmatic, he's honest, and there's not a lot of BS involved in what he's going to tell you. And I know that most of us sit in these groups all day long and we ask questions like, you know, I have an employee who did this, or I've got a patient who said this, or I was told. My favorite, which is the reason he's here with you tonight, is because I was told that if you take a CBCT, you are responsible for diagnosing everything that's on there. And it wasn't until I think it was in Palm Springs 2 years ago that I saw you speak about that at the joint AAM-OMS ortho meeting, where you said that's not true. And everybody's eyes in the whole room just sort of went like that. And I figured, you know, he's not only going to be a great asset for the Orthopreneurs meeting in June, but for our group to have some private time with him. So with that, I'd like to introduce you to Art Curley. And Art, it's yours. Take it away with whatever you like.
All right. Well, let me start off by introducing myself a little bit more and who I am. I'm a practicing trial attorney. I'm based out of California. I've been defending the dental profession for about 43 years. I started the profession, if you will, while I was in law school, where my roommate was in dental school, and I learned a lot of dentistry, whether I wanted to learn it or not, because I heard about occlusion and crowns and preparation. In fact, he even had a dental lab in the back of the apartment so he could do his homework at home and not have to do it at school. And I learned about lost wax investment and prepping crowns. About 4 months after being admitted to the bar, I tried my first dental malpractice case, a numb lip after the extraction of a third molar. I was scared because I knew in 1975, if I lost that verdict, it could be as high as $50,000 for a numb lip. Well, that didn't sound like much. But here in California, where we have the highest priced real estate in the nation, in 1975, you could go to the most expensive areas of Bel Air or Tiburon in California. You could buy a 4-bedroom, 3-bath home for $50,000 and have money left over to buy a car. Today, a numb lip from a dental implant will get you a $1.7 million verdict in California and a $2.4 million for a numb lip after the extraction of a third molar in New Jersey. So times have changed, and I'm unfortunately as busy as ever with new claims, and orthodontics is one of them. So I'll tell you the good news about ortho. It is one of the lower claims. In other words, frequency-wise. If you'd like to get more invested in claims, go to oral surgery school. You have a 100% probability of having a claim if you're an oral surgeon at least once in your career. But the bad news is that the claims, when they do happen, are larger than ever. We're seeing a growth in the verdicts nationwide, and a lot of it has to do with the fact that the dollar just isn't worth as much as it used to be, and juries are much more willing to give a lot of money out. What was considered $1,000 in the 1970s is $1 million today to buy the same thing. And if you think about real estate and other things, it's about the same thing. What I'd like to do is, in my program, talk about the current state of the law, where things are going, and then toward the second half of the program, open it up for individual questions, as your host mentioned, cone beam CT and things of that nature. So let's talk about, again, what we do as a law firm. We represent dentists on behalf of 13 different insurance carriers. We help dentists in cases involving claims such as partnership breakups, employment claims, and so forth. So we hear a broad variety, and my lecture includes a little bit about that, or my discussion. So I want to talk about the legal landscapes, the issues presented, and where we're going. And I also want to mention digital dentistry. As you know, I've been doing this a long time, and digital dentistry is the biggest change I've seen. And it has changed imaging, record keeping, and communications, and along the way, the standard of care. And that's true in orthodontics as well. Let me give you a brief overview of the law and what we see in the law there. First thing to know is that Malpractice litigation is similar to that of an auto claim in that it's a three-legged stool. If you have a three-legged stool and you lose any one leg, the stool falls over, you don't have a claim. So number one, you have to have negligence that causes an injury. Any one of those legs fall off, you don't have a problem. Let's say you have a patient, simpler one is you give them penicillin, but you didn't look at the chart or the health history to see they had an allergy to amoxicillin. But on this occasion, when you give it to them, we all agree that's malpractice, they don't have a reaction. The leg of causation falls off the stool, you don't have a claim. In contrast, you give somebody penicillin, amoxicillin, they've never had it before, no history of allergy. So that's not malpractice if it's appropriate at the time. However, on this occasion, it causes a severe allergic reaction. That's a risk of the procedure. It's a risk of the treatment. It's not malpractice, even though the conduct caused the injury, it was not negligence. Now, an important proviso for all of you to understand is the dental boards in America are more active than ever. Part of it is publicity. You're the victims as well as the benefactors of our social media. When people are unhappy with the dentist, they'll post it on the internet overnight. If they don't like their orthodontic result, they'll put pictures on Instagram and say, look how horrible this is. And when somebody has a serious complication like failure to diagnose cancer while under orthodontic care, that'll end up on the internet and it'll get publicity. And the next thing you know, the dental boards get heard. That is, they have an audience there and they start making changes, investigating the doctors. Things can get pretty ugly. So we're seeing them more active than ever. But an important thing to know about the three-legged stool, the dental board only needs one leg. All they have to show is that you were negligent or didn't adhere to the standard of care, record keeping, diagnosing, imaging, things of that nature. And they can cite your license, penalize you, or in rare cases, even revoke your license. So you don't have to feel that if there's no injury or something of that nature, patient's not going to come after you through the dental board. They can make a complaint. Some states, like Texas, is very active, particularly in certain areas like anesthesia where you've had pediatric deaths. Again, it doesn't affect orthodontics, but it is an area where the board gets more funding and they get more involved. So with that in mind, let's talk about other issues, and that is, when are you particularly liable? If you have negligence that causes a standard of care, you can be liable. You can also be liable for the negligence of others. If you send somebody to someone else, you're the referral doctor, and that person makes a mistake, that potentially could be a negligent referral if you had reason to believe that that person had issues. More importantly, if you have a problem, let's say you don't manage a case correctly, you get root resorption, you don't diagnose it right away, someone else treats a patient and they make a mistake in trying to fix the root resorption, they can sue both of you by saying, but for your negligence, I would have never experienced the other person's negligence. And we call that the deep pocket rule, particularly when the other person doesn't have any insurance or inadequate insurance. They can sue any one of the defendants. So my tip for you, and which is why I like to speak to people who work in study clubs and groups, is always have a circle of influence, people with whom you can refer. As orthodontics, there may be an oral surgeon, a general dentist, someone who can handle complications, find treatment, get the best benefit for the patient without involving outside people who are often very critical. Most of my cases come from general dentists who see a patient from another office and say, that's wrong, that shouldn't happen, and that's why the patient files a suit. And then later on, when they have to give testimony in a deposition, they're often heard to say, no, that's not quite what I said, but the case is typically started at that point. Now, as the orthodontic field, the question for you is, what is the area of claims that I'm seeing? And I do lecture nationally. I'm involved in a lot of national organizations that we get information from. So let me give you a list of where I see the claims coming in on a regular basis. Number one is, surprisingly, the treatment just took too long. And with that, complications can happen. When you're out of treatment at 4 and 5 and 6 years, it may be that the patient's not cooperating, not keeping their elastics or retainers on. But in reality, you're not charting the missed appointments. So my first tip on that one is make sure that when you have patients who are not following instructions, not cooperating, it's always documented. It's too easy to get into the syndrome of, well, the patient doesn't care, hard for us to care. Every missed appointment, every evidence of failure has to be documented. And then when it's repeated, you have to document that they were warned of the consequences. Remember, patients get to be stupid. They don't have the dental degree. They don't have the advanced training. A jury in all 50 states will be comprised mostly of patients, not dentists. It is rare, if ever, to see a dentist on a jury. They usually get excluded. So they count on that. Another one is root resorption, particularly in a rapid movement, particularly where originally the roots are, one of the theories now is that if they're close to one of the plates and they're pushed against either the labial or palatal plate, buccal or lingual bone, they may have a tendency toward root resorption, particularly in the anteriors. So what is your imaging? And have you done some studies when they're under power as to whether or not they're experiencing this? Because we know if we stop loading the teeth, the root resorption stops. So your record should reflect that you took some imaging or some evaluation along the way, particularly if you're loading up the case for imaging purposes, if you're loading with springs and elastics and so forth. Periodontal issues. That's a very common claim where they have a degradation of the periodontal status. The orthodontist isn't monitoring it because, well, they assume somebody else. They assume the general dentist is. And they turn around, and I've had a number of cases where the person has a bunch of straight teeth that are going to fall out. They're straight, but they've lost 50% of their bone. So you've got to look at periodontal disease aggravated by bone loss and document. And one of the things to do to make it simple for you is to document the absence of a problem, that you did a periodontal screening, it was WNL, that you did imaging and the bone was WNL, the roots were normal. Document the absence of these problems to stay out of trouble. One of the biggest issues now is a lack of imaging. And I'll happy to take questions from the audience on this, but I think your industry in particular is moving toward the direction that 3D cone beam imaging is the standard of care. Now, I don't set the standard of care. Lawyers don't do that. I'm the weatherman. I don't make the weather. I just tell you what's happening. But most of the large cases I see now are where the orthodontist did not take cone beam and missed some particular problem. So let me talk about lack of imaging claims. Number one is lack of regular imaging by somebody and missing a lesion. The fact that you're not the general dentist and orthodontist only does not absolve you of potential liability. Got an active case right now where the orthodontist took a Panorex and assumed that the general dentist would be taking images, as he assumed they had had it before, but never asked for copies or verification. The patient was under care for several years with the doctor, got reasonable result, but then noticed some pain or difficulties in their teeth, went to the dentist who then said something's wrong and finally took some x-rays, having not taken films for 13 years. They took imaging and there was a large aminoblastoma that probably existed during the early visits with the orthodontist, but was not picked up by anybody. They sue everybody in this case, the orthodontics and the general dentist. So don't assume someone else is taking imaging. The second thing is, depending on your imaging system, I don't know how many people use cone beam, how many use current Panorex, but I know the old Panorex, they cut out the symphysis and you couldn't see anything, and it often masked lesions and you didn't do anything. Granted, you're looking at teeth and occlusion, you're not looking necessarily for lesions, but once you take an image that is a dental image, that is from here to here and from here to here, you're responsible for what's on that image. That's true in all 50 states. Another thing to look at is the lack of documentation of informed consent of these problems. Patients are often given consent forms to take home and sign, and then they don't bring them back. They're not complete and they're not dated. Informed consent is a mandate in all dental treatments. There's no excuse for not doing informed consent. And you need to document. Most of the orthodontic societies, insurance companies have ideal forms, often vetted by attorneys like me. So let me give you a tip on that. When you start treatment, verbally get the informed consent, then have them document, and the patient has to sign it or the parent has to sign it. It always has to be dated. It's not valid if it's not dated. And then in the law of all 50 states, you cannot delegate to staff in a form the duty of informed consent. You must do it. And the only way to document it at some point, the staff can help, the movies can help, the books can help, and you document all that. But at some point, the doctor has to sign off, and the way to do that is to sign the consent form. So one of your tips should be before you start orthodontics, once you start to apply or your staff apply that first band, have a timeout and make sure you do a checklist and whether or not you have a signed, dated, and countersigned by the doctor consent form on file in the screen, on the system, or in paper. We also have today a new doctrine for many of you. It's called informed refusal, and it's actually the bigger risk for you. And that is when a patient turns down ideal treatment and they incur risks because of that ideal treatment. Simple example that doesn't apply to you often is you have a patient with a large lesion that you do diagnose, but you don't know what it is. And you send them to an oral surgeon and they refuse or decline to go. Do you just do nothing and say, hey, I told them, they didn't go? What you often can do in that case is do what's called informed refusal documentation. And you have a simple note that says patient advised to go to oral surgeon to evaluate lesion. Then you put risk, benefits, and alternatives discussed, and then you put the worst risk. They won't go to have that lesion looked at. The worst risk is death. They won't go to the periodontist to have their gums evaluated or treatment. They risk losing teeth. You put that down and then you put the patient still declines, and then they sign it. If you do that and the problem gets worse later on, they lose their teeth, periodontal disease, recurrent decay, they don't get the x-ray, whatever it is, you're going to be protected by that informed refusal documentation. But here's the benefit. What we find on nationwide surveys is that this is done over the course of time, these studies, they found that 40% of the time when patients are asked to sign this, they go, wow, it's that important? I didn't know that. Well, gee, even though you just said it to them, 40% of the time they'll say, okay, doctor, I'll do what you said. I'll follow that. So you'll get compliance when you do that. It's a great little tool. It's a short little form. You say patient advised, patient declines, risk, benefits, and alternatives discussed. List the big ones, not everything. Just list the most serious ones. Patient still refuses, have them sign and date it. 40% of the time, they'll say, go ahead and do it. The other 60% of the time, you're protected. Now, if a patient says to you, well, doctor, I don't want to do it, but I don't want to sign this form, you can't continue to treatment. They have just told you they're going to lie because you told them truthfully what the risk benefits are. They refuse to acknowledge it in writing. It's just like a patient who wouldn't sign a consent form. You're going to say, well, then I can't treat you. If you want to acknowledge this discussion, they're saying to you, I'm going to lie along the way. Another thing we see sometimes, particularly if you're affecting the occlusion, is the onset of TMJ. Your records always have to reflect a startup exam, particularly in adults, less so in minors, which a lot of your work is, that there is no TMJ. The TMJ excursion is normal, no clicks, no pops or stops or any pain on translation or movement. Just put TMJ, EX, WNL. That's all you need. Don't say, I only put it down when it's abnormal. You don't want to get in this he said, she said contest. One of the things that makes it very important is your health histories. Patients today have more problems than ever. Diabetes is rampant in America. Chemical treatments for people. Everybody turns on a TV and they want drugs. Why? Because they see a happy couple running around taking Abilify. My physician clients tell me, I'm having a problem. People coming in demanding drugs. They say, I want Abilify. You don't need Abilify. I don't care. Those people are happy. I want Abilify. And so you need to know what kind of drugs they're on because they can affect how well the teeth move and how the gums react if they have things that have contraindications. And when they write down that history, you better have showed that you explored the potential side effects and consequences for orthodontic treatment of any drugs that are on, particularly in adults. When you have consent forms that you use, you always want to discuss root resorption, periodontal disease, caries, and aggravation of any TMJ or TMD problems. And again, use the forms you have along the way. When do you have to refer out? You only have to refer out if you're not experiencing that particular problem, since you're the one who gets the referral. But again, if there's a lesion, there's an x-ray image, you're not clear on it, you need to refer that out, document, and when they don't do it, get informed refusal. Now, one of the things that comes up is in your informed consent, you have risk. And when they have this problem, you say, well, root resorption was a risk. Recurrent caries is a risk. Periodontal disease is a risk, so I'm not at fault. Under the law, a risk is a complication that is not avoidable if you use standard of care skill, management, and technology, which you have to document. Those three elements: skill, management care, and technology. For example, as I already indicated, root resorption, that's a risk. Is it avoidable? Well, you can avoid the severity of it if you take serial images early on to see if it's happening, record that, and record the absence of it. If you don't, it's a lack of technology using imaging. Again, if you have any kind of physical management of a patient or mismanagement, you take and lose control of a wire and you stick it right through their cheek, that's a lack of skill, and it's avoidable. So the techniques for you, for the most part, are documentation that you had appropriate care with the health history, and you weren't aware of these potential complications because you weren't told about drugs, but they negatively said no drugs. Once you get that information, you have to analyze it, and you've taken appropriate imaging. One of the things you do more so than most general dentists in your documentation is photographs. You, for years, have had a little startup sheet with the frontal, side, and so forth. Today, photographs are more important than ever. Most people today who have a cell phone have tons of photos, mostly of their lunch and their friends and their cats, but they have a lot. Most of my dental clients don't use their cameras to the extent they should. They underutilize it. And it's the greatest tool possible. In orthodontics, I would like to see you use it a lot more because it says so much. If you see some evidence of occlusal grinding, you see evidence of root resorption, you see some characteristics in the mouth, do you want to write long paragraphs, or do you want to take good intraoral pictures with an intraoral wand or camera that shows all the root resorption, that shows any notching or what we call abrasions or abfractions? Do you want to show that or write it all down? If you take good films, not just your startup, but take good color imaging in focus of that, you'll have a record. If I want to record all the resorption, just gingival resorption around the teeth that I'm going to work on, all I would do is put in my lip retractor and take pictures. I'm going to know the name of the tooth, the number it, and if I stick a rule in there, I'll even know how much it is without having to write it all down. And I would say, gingival recession, see photo. So it's a tremendous tool. It's underused. You do it at the finish. But for those of you who use conventional plaster of Paris models, take pictures of them. If you lose them or break them, you got pictures. Put a ruler by them. Have the patient's name next to them. Terrific tool. Storing digital images is cheap. Right now, today at Best Buy, you can buy 4 terabytes of storage for $150. There's no reason not to use lots and lots of photographs along the way. Take a picture inside of their mouth, not just this. Take a picture open, show the restorations, then close-ups if it's going to affect you. Also, what a great way to, when a person's happy with the result, you can do this. I like to tell my clients, when they're happy, they love the smile, take a picture of them going, hugging you. That is great evidence that they're happy with the result, they're comfortable along the way, something of that nature. Some of you can even take certain, well, I guess they call it Vine videos, 6-second videos, you can do that. But put it in the chart, note that they have approval of that along the way. With that said, the next thing that doesn't happen enough is imaging in the cone beam world. Now, again, I'll open it up in the second half of the program to questions. But cone beam, which I lecture on a lot, has opened up a whole new world. It is, in my opinion, the standard of care for evaluating at level 1 TMJs. You can see the cortical outline of the joint, you can see its position, you can see arthritis, you can see beaking, you can see all of these things that might prove a trigger point for your orthodontic treatment in an adult. You can see growth anomalies in these images much better than your Ceph, your lateral, and your pano. In arguments about whether or not cone beam is the standard of care, it's less radiation in a modern machine than a pano, lateral, and frontal Ceph. It's less radiation. It's an 18-second scan that gives you everything from bone quality to tissue overlays to airway math formula diagnosis. Tremendous tools now with overlaying software. Most of my clients now are leaning to the idea that cone beams are the standard of care. Let me give you a thought on where I see some evolving standards of care. And part of your treatment involves an area called sleep apnea. We're seeing cases that are now being published in the literature of children who have sleep apnea, airway obstruction, and they're partially hypoxic. And they're having behavior problems, intellectual developmental problems, and they're diagnosed with an airway problem. They undergo orthodontics at a young age with rapid palatal expansion. Subsequent to that treatment and related orthodontic treatment, the airway is opened up, and there's reports in the literature of improved cognition, test scores, and improved behavior. Now, while that's not the standard of care, and there's a lot of worry about radiation in young people, the benefits outweigh it, and the radiation is much lower. And also, the other thing is to remember you can get limited view x-rays today. People say, and the question was raised by your host, are you liable for everything in an x-ray? No, unless anybody in my audience has an MD, your license is limited to the area from the chin to the maxillary sinuses and from ear to ear. You're not liable outside of that because your license doesn't allow you to do that. And you have holistic dentists and plastic surgeons to thank. Because holistic dentists in many states had said, well, we got to treat this, we got to treat, they did breast exams, they did abdominal exams, we got to treat the whole person. They said, no, that's a practice of medicine. And that many dental boards have said, no, you've got to stay right here, and they define it. Plastic surgeons have come after dentists, general dentists primarily, who are doing aesthetic Botox injections, Restylane, and so forth. They say, no, no, that's outside of the field. That is the practice of medicine. Let me put it to you another way on your concerns that you may have on cone beam. How many of you can see people's foreheads? All of you, right? Unless people come in wearing a hat, which is not really ideal in a dental setting. You can see their foreheads. Do any of you think you're liable for failure to diagnose skin cancer of the forehead? No, you're not licensed for it. None of you would think that. Now, if somebody has some big goochy lesion on their head, you might say, hey, you might want to see a physician of that. I don't know if that's just a pimple. But it's not liability for you. How many can you see their hands? You see their hands? Are you going to be liable for lack of it just because you can see it on an image? No, you're not liable for that. So it doesn't mean you can ignore something and not be ethical about it, but you're more likely to get sued as an orthodontist for lack of imaging. In fact, that's often where I'm seeing the suit. You didn't take enough imaging, you didn't take cone beam, you missed this lesion, then you'll ever be sued for failure to diagnose a brain tumor, vertebral body disorder, carotid artery calcification. Those are all things. If anybody here thinks they're licensed to treat the neck, the brain, or the carotid arteries, let me know, because your state would be very different than the other 50 states I know about. And consequently, it's actually a violation of the Medical Practice Act for you to do that, and therefore you can't diagnose that. Therefore, you can't be liable for failure to diagnose things. Now, from here to here to here to here, absolutely, you better diagnose it all. And if you're not comfortable reading cone beams, then you need to refer them out if you're going to take the appropriate standard of care imaging. But having done a lot of work in cone beams, having successfully tried several cases involving cone beam issues, everybody can read them. Manipulating, making those little white lines go around, the blue lines, the green lines, well, that's a challenge. Seeing the final image, the jury can always see the hole in the head. They can see the big dark area in the chin. They can see that and go, that's not good. And when the radiologist says that's the lesion, the doctor missed it, because if they had taken this imaging, they would have seen it. And they had an obligation to do that along the way for standard screening or something of that nature. That becomes a problem. Now, I'm not saying every patient, for every orthodontic patient, needs a cone beam, but it is evolving. It's something you need to be vigilant at and something you need to look at along the way. Another thing some orthodontists are doing is snoring devices, MRDs, mandibular repositioning devices. They're also doing things in the area of sleep apnea. Couple tips for you there. As a dentist, you can't diagnose sleep apnea. It is a medical diagnosis. Once that medical diagnosis, usually through sleep studies, is made as to whether or not it's central, which is not obstructive, or obstructive, which can be dental treatment, only with that diagnosis can you become involved with something like a medical device, such as a night guard, but a mandibular repositioning device. And then you have to make sure there are no incipient TMJ problems that are ready to fire off if they start loading up with one of these devices. But the standard of care is not there yet, but I'm seeing hints that diagnosing or considering or recommending for a sleep study is becoming more and more of a concern in the dental community for general dentists and orthodontists. When patient reports certain symptoms and so forth, why didn't my doctor tell me about this? It's still mostly in the medical field. It isn't yet catching up, but because you're doing a lot of this work, and there are a lot of you that are promoting snoring devices, we do this, we do devices for sleep apnea, I believe it's not going to be too long before we see the first cases saying that you should have diagnosed it and recommended treatment or at least a referral for a diagnosis. So be vigilant of that, be careful of that at this point as you get in that field and you see more and more patients in a screening exam. As far as cone beam, what I'd like to see for most situation is a screening or initial exam. Then you can take some serial films or even Panorexes or something simple to look for root resorption, and then a final cone beam toward the end to make sure you're covered. And again, if you're just moving one tooth, you're not moving another, you're not doing this, you've got to gauge. You can have much more limited. One size fits all is not what I'm saying. But the full banding cases, the cases where you're going to close spaces, where you're working, if you're already working in an orthodontic case, then there's going to be cone beam. Because right now, about 80% of the oral surgeons in America are routinely using cone beam. It's ubiquitous in that community. I'm talking about just by yourself, and don't rely on the general dentist to do that. Finally, if you get into disputes with a patient, almost all 50 states, right now about 45 out of 50 states, have a law called, it's either the refund or the settlement law or a Good Samaritan rule. They call it Samaritan rule. When you try to settle a dispute, the patient says, you know, the bite just isn't right. I don't feel it's right. I don't like that. And I want my money back, or I want to do something like that. If you say, look, you didn't come in for a lot of visits, so forth. I know you're not happy with the results. It's not my best result, but it's part of your fault. I'll meet you in the middle. Of the $8,000 you gave me, I'll give you $2,500. That was your deductible from insurance or whatever. If you do that and then it breaks down, they don't want to do that, that's never admissible in court. You'll settle and resolve a lot of things before going to court by considering in bad outcomes, less than ideal outcomes, that you'll do some form of resolution there. Tips for you. One, if it's a chunk of money in the thousands, call one of your insurance companies or attorneys like myself, get a written release that the patient says in exchange for this payment, I won't sue you. I waive all rights to do so. The other thing is never confess fault. Never say to them, here's your money back. I got to do a better job because I really messed this one up. Don't do that. Just say, look, we try to please. Sorry you're not happy. We stand behind our work. I'm willing to offer you a refund. If they decide to sue you, that will never be admissible in courts. That'll all be kept out along the way. Even if you negotiate, they want a little more, you want a little less, you go back and forth. Just make sure, number one, that's not in the chart. That's a separate note because that has nothing to do with treatment. Because once you have it in the chart, you can't take it out of the chart. And if you call your insurance company to get advice or an attorney, don't put it in the chart. And you can resolve a lot. One of the ways the large clinics I work with on a regular basis don't get sued all the time is when people really gripe, they give them a refund. Just say, move on. We got too many patients sitting in the waiting room. And we don't need that. We don't need the bad publicity. And in fact, one of the things we do in our releases, we put a non-disparagement clause. You get your money back and we agree confidentiality. You're not going to go on Yelp and say, this doctor gave me $2,500. He's terrible, but I'm okay with it now. So get a little legal advice if you need to on these resolutions, but consider sometimes the disputes with the patients, they don't like the outcome, how long it takes. You give them a partial refund or give them a little bit of their money back. It's great to get a release and resolve that along the way, and you can avoid this. And then the last thing to remember is that most of your insurance carrier, I know some of you with AOIC, there's other companies, private carriers, they often have a 1-800 helpline. You can call them. Tell them you've got a dispute or patients had a bad result or something of that nature. Get advice. They usually don't put it down. Oh, the doctor's calling me again and again. I go on a blackboard and write it down. They're hoping the ounce of prevention is the pound of cure, and they do that. I've had carriers tell me the guy's called 10 times and never been sued, and they've never changed his rate because they know he's being proactive along the way. You're doing a little bit of that proactive by taking a course like this and getting a tune-up. I hope I've covered a little bit of a background, and as your host said, we're going to allow some time for questions here, and I think we're at that point. And so I know there's some chat questions. Maybe, Glenn, you can tell me if we just do this verbally or if I need to chat on some written questions. I don't know how the software works, so I'm open.
Thanks, Art. First of all, every time I watch you, my head spins and I want to get my office manager here to take notes on all this. I'm the son of an attorney. My aunt was an attorney. My uncle was an attorney, right? I'm Jewish. I got 11 attorneys in my family, okay? And they all sue each other. The interesting thing that maybe other people never noticed is that until tonight, how many of you out there did not realize how much attorneys knew about what we do? When he talked about moving teeth and resorption being related to buccal or lingual plate, right? And if you think that this is an unusual thing and that attorneys don't know this, but Art does because he's speaking to us, find yourself in a courtroom sometime and you will be absolutely amazed. I had to be deposed once and it blew me away. So don't think that things happen and don't worry, the attorney will never figure it out. They will uncover everything because this is what they do. And I'm really thankful to have folks like you, Art, on our side because you defended the dentists. And I really appreciate what you bring to the table, but it's amazing how much you know about orthodontics. So thank you.
Part of it I have to know about that is because there's a lot of attorneys that know a lot too. Every state has an average of 3 to 5 dentists who went to law school and assist in or specialize in suing dentists. There's even one attorney who wrote a book on how to sue dentists, a guy named Norm Schaffler out of Southern California. They often will go to other states and assist attorneys. The $2.3 million numb lip verdict out of New Jersey was assisted by an attorney who went to dental school for a year and then decided he can make more money as an attorney. There's some attorneys are also periodontists, oral surgeons, and specialists like that. They're out there. There's on the internet. In fact, if you dial up the word dental malpractice, you're liable to get an attorney who specializes in that when you look it up. So patients have access to that information, and I got to keep up with it.
Well, we appreciate it. So I want to open up. There's a ton of questions, but a couple of thoughts that came to mind as you were speaking, specifically about CBCT. And I'll hit you with 3 quick questions. The first is, at what point is, if you're going to do, I got a sense, it's simply yes or no, I guess. I got a sense that there's never a case that you can come up with for a comprehensive orthodontic situation where you could say, well, you know, I don't need a CBCT because this is overkill. I just need a PAN, a CEF. If the radiation issues they don't trump it. If you have a CBCT and ability to, it's always a better option for a comprehensive case, yes?
You get so much more information. And while it won't help you on every single case get some surprise, how many surprises do you need? How many missed lesions do you need that on a plain 2D Panorex is a faint shadow, on a cone beam is clear as day? When you go back, and just like when you all went to school, you looked at an x-ray, you didn't see anything. Your instructor said, you see that shadow? Here it is. And now, once it's pointed out to you, you go, oh, yeah, that could be. I guess that could be. Now it is consistent. That could be this. And patients today have weird lesions that show up slowly and develop. And you're, unlike some general dentists who see the patient once in a while, you're seeing them regularly over a course of years. And so that becomes an issue. So I don't, and what I'm being told by the radiologist and medical physicist is that the current generation machines are less radiation than the combined radiation of a lateral, frontal, and pano.
Okay, I appreciate it. So the only other question I have for you related to this is, we're not liable to read what's on there. We're liable to read, as you said, from here to here. That's our area that we have to read. But
Right.
The other misnomer or folk legend that's out there is that when we take a pan, even though we're liable for reading this section, are we liable for sending out the x-ray to be read by somebody to read the rest of it? Because we took the x-ray, are we responsible not for us reading, but for anything that could be on there for somebody else to look at?
Not really. If you get reasonably, you're not really liable if you're not, well, let me phrase it. If you don't know how to read it, you don't know how to read x-rays, yeah, you're liable for missing stuff. But I've never found any dentist who can read a Panorex, can read periapicals, who can't read a cone beam. What they don't do is learn to manipulate so you can see sagittal slices, so you can see coronal slices, so you scan through it all. Once you learn to manipulate your system to move the windows around and get the views are not hard to read. Every case I've tried, the jury can read the image. Once it's put up on the screen and they see the sagittal view, they see the frontal view, they see whatever it is, and they can see this big hole in the jaw. It's a big dark area, this big, and it shows just perfect. On a cone beam, it's fuzzy on a standard old-fashioned Panorex. There's where the dispute comes in. It's not that you're going to miss something. It's really hard to miss it. I can read most any cone beam. The task is learning to manipulate. So that's your obligation. Learn how to move through the various views and scans and click on it. But my problem is I have to do that in about 20 different programs because I don't have a machine. I get everybody else's data.
But my question, I guess I misstated it, is that we agree that we're responsible for everything here and to manipulate and to read. Am I responsible for sending out for reading?
No. Only if you think you can't read it. Now, the reason that came up, let me tell you the origin of that. If you're an oral surgeon, MD, DDS, I have to tell you, you're liable for everything on the film. You're a physician. You're liable to diagnose everything in any image, all the way to here, all the way to here. And so there's been this discussion out there in the industry that you've got to send it out. That's why orthopedists who can read really good x-rays, they're really good at it, still send it to a radiologist because it's such a broad field. They don't want to miss anything because they're concentrated on the kneecap. That's their specialty, the ankle, but it shows the whole leg, and maybe they're missing something faint there that radiologists would pick up because they're liable for everything. You're not.
Okay.
And so unless you don't know how to read a cone beam, which means you don't know how to read x-rays, you don't have to send it out.
Okay, excellent. So let me get into some of the questions real quickly. One of the questions says, in general, what is okay to discuss with a patient and write in the chart versus what should you have in writing and have the patient sign? So I guess the question is, if I write something to a patient about their case that's outside the ordinary findings, at what point do I have them sign that?
The signature for a patient is typically instructions, informed consent, informed refusal. The patients don't have to sign your correspondence to them if you sign it and mail it to them or email it to them. They don't have to sign off on it. If you're making chart notes of your findings, they don't have to sign off on the notes. The signature is really where you're documenting a communication with the patient that involves warnings, risk, instructions, things of that nature. And even then, when they're pat, you can chart like gave patient post-operative instruction sheet. They don't have to sign that they got it. You have it in the chart. It's pretty routine. But the emphasis that I like on signatures is the signed dated health history, signed dated consent forms, signed dated any kind of warnings like informed refusal. Okay. But they don't have to routinely sign the chart or the discussions. Now, the only thing you write outside of the chart is something wherein it's not treatment, and like settlement discussions or some personal communications about some personal problems, or somehow they discuss it with you or send you an email. Put that separate than don't put it in the progress notes.
Okay, excellent, thank you. Next one, my software does not time date my treatment findings and my treatment plan. Does what so just so you know, Art, there are certain programs, mine included, that when I put in my treatment plan, I have no doubt that somewhere you could, in the coding, you could probably look back and see a timestamp, but it doesn't say when I do it in front of me what the time and date was of me putting in my treatment plan. So the question that was asked is, does what I write in my findings still hold up even when right there in front of you it's not time dated? But I would have to believe that a forensic specialist would look through it and be able to find a timestamp, no?
Well, a couple of things what you can do is explore what your software does by printing out pages of your treatment chart. You'll often find that while you don't see it on the screen, when you print it out, the date's there. Okay. So that's one thing. Number two, all electronic software has what's called an audit trail. The audit trail can be sought out. You may have to talk to your tech. It'll show you who was logged in, what computer terminal they went in, and what they did. They looked at the chart. They modified the chart. And if it's a program they called up, it'll say, looked at treatment plan. That's available in as you say, forensic. It's an audit trail. Good plaintiff's attorney asks for that audit trail because the doctors say, I didn't do this, or somebody else, I didn't do that, someone else, and they can find it in the audit trail. But test it with that. And if you test it and it still doesn't date it, you need to dictate that into the chart, because most of your state laws require that all entries be dated and initialed or signed by the doctor. If it's not doing that, then you need to make sure you do it manually.
And I assume also that a good idea for all of us is, if there's a concern, to call our software company and ask them, what kind of compliance do they have with these sorts of laws? What kind of attention have they paid to these? And to give that to us in writing, so at least we understand where we stand.
Oh yeah, you'll often get them to come out and modify, because you say, I'm looking at other programs and they do this. Does yours do that? And they'll often call you and say, well, it will do. We'll be out there. We'll upgrade it.
There's a ton of questions related to informed refusal, but I want to ask you a question real quick that I know we talk about online all the time. And we've been talking about negligence, right? We've been talking about all the things here. What we haven't talked about at all tonight, because you just don't have time, and I hope that in June at the big meeting, we'll be able to maybe broach it for a moment or two when we take some questions, is social media, right? For me to be able to post a picture of me and that 8-year-old kid, or mom, or that patient. If I say to a patient who's in the chair, and I had a simple line that says, I allow Dr. Krieger to use photos and casts for educational and promotional purposes, that they sign when they start with me. And then 9 months later, little Jimmy loves his smile, and mom says, you're the greatest. And I say, Mom, do you mind if I take a quick picture with him? I want to put this on Instagram. And she takes my phone, takes the picture. She says, no problem. And I post it on Instagram. Am I covered? Or do I have to be very careful when I do these things?
You're now talking about HIPAA promotional law. And HIPAA is particularly specific that when you use imaging of a patient where the fact that you did a particular treatment is associated with their name or their face, you need a written consent for doing that, and that it emphasizes that it's for promotional purposes rather than just being stored for educational or documenting, which you would do with all your charts anyway. And normally, that's not what HIPAA is intended to do. So if it's been a while, let's say you do it in the beginning, you get a release, I would get a new one toward the end. These releases are not infinite for the rest of their life. You're in a position where you really need to consider another written release. It's easy to do. You can do it through an email. And you also need to somehow have it. The ideal is they release the specific image, unless you have a statement, all images taken at the office at that point. But again, that's okay to use the image, but you've got to be very careful how much you talk about the child at this point, because you still have confidentiality requirements.
Right.
For example, if you're going to say, look what I did with this Down syndrome child who had a prognathic mandible, we were able to do that, and he functions better and so forth, that's pretty personal, and I think you need to get a specific release to discuss that background. HIPAA is very strong on what you can do for promotional purposes.
Unless I de-identify them, correct?
Right. HIPAA, it's called PHI, Protected Health Information. Two things always have to be next to each other: the identity of the patient and the treatment. If you just have patient, John Smith is my patient, there's no confidentiality. They waived that when they walked in the front door.
Right.
If you say, I have a patient with Down syndrome who I straightened all their teeth, but you don't say the name and there's no photograph or identifying marks, you don't have PHI. It's the two together, the name or identity in photographs or other thing, and the treatment.
Got it. So if I had a
medical history.
If I had a picture, Art, with me next to you, my arm around you, and said, man, look at Art's smile. He's such a rock star. That's not a violation, because I didn't say what I did. I just have a picture of Art and his smile, correct?
It would be, unless, theoretically, you have your name underneath that. It says orthodontist. It sort of implies that, but theoretically, no, because you don't say, I straightened their teeth.
Got it.
Again, orthodontics is not like having plastic surgery, gallbladder, or a hysterectomy, where it's these are very private things along the way. And so dentistry doesn't quite have the onerous burden on it. If you're in psychiatry, you can't put anything up.
Okay. So another question. If a patient comes in for a retainer replacement, whether they're your patient or somebody else's patient, but my assumption here is it's your patient, comes in, they want a new retainer, do you need to go through a full diagnosis and a full set of records just to make them a new retainer, assuming you made them one 2 years ago and it broke and now they need a new one?
No. It's a question of you're just screening out anything. So you would ask them generally, are there any changes in their health history to update it? You would ask them, you would do a very cursory exam, for example, just a quick TMJ exam, and you would chart TMJ, EX, WNL, just to screen out any gross anomalies along the way and a very short history. But you don't have to do the whole detailed one, a new history form, new imaging, new x-rays, and so forth, because they're really a post-finished treatment patient. You're just following up. It's kind of like doing a cleaning on a patient who's already had the crowns. You don't have to re-image all the crowns other than your typical caries control imaging.
Okay, great. Do we need full records on a recall patient who hasn't started active treatment yet, or is a clinical exam and a Panorex enough if they've been taken so essentially in orthodontics, we might see an 8-year, I assume that this is your question, and please jump in if it's not. But my question that I think I'm reading here is that if you have a 6-year-old kid, they come in, they get a pan, a full exam, and then every 6 months to a year, you're taking another Panorex, you're following them longitudinally, and then I'm going to start their treatment now. What do I need more than, do I need to do a full exam again when I start them? Or is that periodic, hey, no changes, they look great, everything's wonderful, here's a Panorex, no pathology, TMJ is great, no extraoral pathology. Is that enough, or do I need to go back and do a full exam again?
No, I think that's enough. I think
okay.
Because you're looking for changes. And again, if you see any triggers, if there are any changes in their health history, they're on new medications, new drugs, or something, you may have to follow any significant changes. So what you just mentioned is a update of the TMJ, update of their health history, oral exam update, a minimum oral exam, a CA screening exam. I think that's all you really need in those cases.
And Kristen, I think that's your question. Did I hit your question properly there? If I did, you can give me a thumbs up on the screen. If I didn't, you can send me to the Lions. Okay, cool. Another question is, someone comes in, Art, you came in, I start straightening you 6 months in. I said to you, hey, I can't get you straight without taking out teeth. And you agree to it. And you say, sure, we're going to take out four teeth because you weren't wearing your rubber bands the way I told you to. Is that something I would assume that I'm going to put in writing and get a signature on? That Art did not wear his rubber bands as directed. Now we are changing the treatment plan because of this. He's been informed of all the pros and cons of this particular procedure and agrees that he will do what we ask moving forward, or something along those lines. And have you signed
updated treatment plans are the most underutilized tools out there. Don't just make a chart note. Give them essentially a new treatment plan or updated treatment plan and have them sign on and specifically indicate in that. And then your chart should show why. Failure to wear elastics, patient understands, options discussed, things of that nature. And you're going to need new informed consent because now you have a different treatment. This is a space closing procedure where before it was a leveling and rotating procedure. So you need to consider perhaps an updated consent form, particularly if it's been a year or two.
Okay.
And you now have a new treatment plan. It may be the same risk, but you need to have a new form because you're changing the treatment plan.
Okay.
And the patients get to say, I didn't know. I figured that treatment plan didn't have these risks. I don't know. I'm a dummy.
Okay. I just have a couple more questions, and I appreciate everything here. From Ruse, he asks, what parts of communication with other providers should be in the patient chart and what parts should be in a separate document? In other words, what should we not add to the patient chart when we talk to our collaborators? And my assumption is anything that's not pertinent to their treatment, don't discuss in the chart.
Well, the question is, why are you having those other discussions anyway? If you're having, because the problem is you can't control what other people are recording. And while you may not record something that has to do with their personality or something, these could be germane. So if you're talking with a healthcare provider and they're discussing their treatment of a patient, their evaluation of the patient, you certainly need to document that.
Okay, but I think the question stems here, and Ruse, please correct me if I'm wrong, but many of us have very close relationships with our oral surgeons, our general dentists, and you'll often hear somebody say, hey, Glenn, I'm sending you this patient. She's bananas. This woman, she's been to 6 other orthodontists. If you don't want to deal with this woman, just tell her you don't want to treat. Some one of those kinds of questions. My assumption is you never ever put that stuff in the chart. You put in referred by so and so, or here's a chief complaint, and just things that are germane to the story. Correct?
Right. Or you can translate what they're saying because they're trying to tell you something. This person is bananas. Talk to Dr. So-and-so, discuss concerns about the patient's ability to cooperate and approve. It's important enough for them to tell you got to chart that. Just take out the colloquialisms and so forth.
Okay.
But if you're having a lot of discussions about a problem patient, it's got to be because it's going to affect you. And that's the very thing I don't get, and I need to defend you. Just translate it into professional language along the way.
Got it.
And little tip here, don't try to hide it like PIA in the chart. Everybody knows what pain in the assets means.
Okay. Just 2 more questions for you, sir. You mentioned state board. State board only has one thing they've got to basically prove. What rights do most of us have in front of a state board? If a state board were to say to you, God forbid, hey, your assistants have been doing work that they're not allowed to under the law, and you believe, based upon interpreting and looking at it, that there's no way that that could possibly fall under the law. In Texas right now, it's the use of hand pieces to clean off cement and only cement. What rights does one have if you ever find yourself in front of a state board? Do you just sort of bow and say, I'm sorry, I won't do it again? Do you go get an attorney and say, well, now I'm going to make a big stink of this, but maybe I'm in for more hell to pay? What's your suggestion if one is ever called before a state board?
Well, very quick, that brings up a subject, and I know we're getting short on time. Number 1, never communicate with the state board without getting legal advice. Basically, everything you say will be used against you. These are cops looking for a collar, a star to put on their shoulder, and they're trying to collect this and trying to see if you're compliant. So number 1, often you have insurance that will cover that. So that'll cover the attorney's fees along the way. And I consult with people this all the time. And number two, you do have a right to present your own evidence to them. They'll often, if it's early stage, they'll want to interview your staff and look at your records. If you got good records, that'll disabuse their notion. But you have a right to contradict that, to show your own expert testimony, and present your own evidence. They have an absolute right. It's called due process. You don't have to accept whatever they want. Often what they do, quick tip, the number one reason for a board investigation is they got a written complaint. They will come to you and ask, how do you respond to this? And give me a copy of your records. Hopefully your records are in good shape. You then get advice and do a very high-end narrative. Sometimes you even include a statement from another doctor supporting your care. I always try to overwhelm the board with evidence. You don't have to tell them you have an attorney do it. I design a binder, we put all the response, and we send it back. That is how 99% of all board investigations that are about quality of care start. If a board doesn't give you that notice and opportunity, and they just march in your office, it's not good. That means they've either been advised of billing fraud or sexual assault, and they never give you notice. They just come in with badges blazing. Even there, I tell my clients, if that ever happens, you call me on the phone, and I'm going to stop the interview right now because this is quasi-criminal. So always get advice before you respond, and you'll always be given an opportunity and time to respond and seize upon that. It isn't just where you're going to be dragged off.
Okay. My final question for the evening, Art, and I do appreciate your time on this, and I think it may make you laugh a little bit. Where do you see, well, how is Smile Direct Club getting away with what they're doing, and where do you see them in the future? Is this a giant monster that's going to get taken down legally, or do you see this as something that's here to stay and all their complaints are never going to do a thing against them?
Smile Direct meaning non-dentally provided aligners.
Yeah, specifically the Smile Direct Club that's trying to be $1 billion company that's
Right.
getting complaints at this point. The state boards claim they'll do nothing against it, and there's lots of discussions with groups. And from a legal perspective, you're the guy. I figured I'd ask you what your thoughts are on the future of this technology.
Well, any technology that provides what is described in a Dental Practice Act as dental care requires the provision of the treatment by a licensed dentist. The question that they're trying to say is this isn't truly dental care, it's self-care. It's like a patient going to a sports store and buying a bite and boil mouth guard or boil and bite mouth guard. It's really not treatment, it's just for football injuries. That's how a lot of the snore guard people have gone, whether it's with ZPA or so forth, where you buy it over the internet. They say, we're not really treating teeth, we're providing them a self-help process. I think what it'll do, it'll stay a little bit out there because there's big money and sometimes they pay off the politicians. When somebody has a really serious problem and some big complications, that's when the government gets involved, the dental boards get involved, and they'll declare it a problem and they'll withcall it. Remember, we're approving drugs every day, and then after the people's left leg falls off, we say, oh, we better call that drug back in. That was wrong. And then the other part of it is you'll learn to love plaintiff's attorneys, because when somebody has a bad mistake, the attorneys will sue them not only for malpractice, but for practicing without a license and doing that because it means more money for them. So my prediction, if you ask where that's going to go, it's when they screw up. I'll give you one last example. We had Botox parties in California for a while. Dentists were going over and doing Botox for all kinds of wrinkles, and nothing was happening because it's, it disperses after a while and so forth, until a couple of people bagged an artery and they got facial necrosis. Now the dental board in California says general dentists can't do Botox for aesthetic reasons. They can do injections that are legal for like TMJ exams, but they can't do it for that. You have to be a physician or a specially licensed oral surgeon. So unfortunately, crisis management is how the boards work. When somebody dies, somebody has a complication, they go to the board, then they'll enforce it. Until then, it'll kind of linger out there for a while.
Okay. Well, thanks, Art, for going a few minutes over. I really appreciate it. If anybody do you only take clients in the state of California, or do you take clients from all over the United States?
I consult on general issues, but I'm not licensed in any other states. I sometimes work with other attorneys to help them and consult on that, but I'm only licensed in California. But I'm happy to take questions sometimes. People, call for a couple minutes, as you have in the past and so forth. I'm always happy to do that. Okay. And I can refer you to colleagues in your state that can help you if it gets more prolonged than that, because I'm a member of a panel of a large group of dental defense attorneys.
So that people who watch this in our private group see this, where can someone reach you if they want to get a hold of you?
Well, they can reach me through you. You can reach me through you and get the contact information through you. That's the easiest one. Okay. And email is often the easiest way to respond, because then I'm not going to be in court or the middle of a consultation, and I can respond to you a lot.
Are you comfortable putting out an email right now for everybody?
Sure. It's ACURLEY, my last name, the initial A, and then the @sign, and then the word professionals, plural, the opposite of the word amateur, professionals, and then a hyphen or a dash, not an underscore, a hyphen or a dash, then the word law, LAW.com. So it's acurley@professionals-law.com.
And the only reason I ask for everybody who's watching this is not so we can pepper him with the continuation of questions here, but so that if you ever run into trouble, or you know somebody who's in trouble and they need to hire counsel, here's your man to reach out to. So Art, I want to thank you from the bottom of my heart for everything you've done here for us this evening. Really looking forward to seeing you in about 47 or 48 days. And I hope everybody here enjoyed this time as much as I did. So anybody wants to continue the discussion in the group, we can. But otherwise, have a wonderful evening. And Art, enjoy what looks to still be sunshine in your part of the world.
Oh, yeah. We're getting our California spring. Thanks, everyone.
Take care.
All right. Bye.